Good afternoon. It is my great pleasure to participate in the International Conference of Oncology and Cancer. I am Yuki Amano, the Department of Neurosurgery at Nakamura Memorial Hospital from Sapporo, Japan. Now, the title for my presentation is Long insular artery damage might be a key sign for predicting functional prognosis of terminal hemorrhage. Putamen is the most common site of all intracerebral hemorrhage, comprising 48 to 67% of all spontaneous ICH. Hemiplegia, which is the main clinical feature following terminal hemorrhage, is related to the anatomical characteristic of putamen, in particular to the proximity of corticospinal tracts. The first multicenter surgical trials in ICH stage found that patients with spontaneous supratentorial ICH in neurosurgical unit show no overall benefit from early surgery compared with initial conservative treatment. Subsequently, the two study confirmed that early surgery within 48 hours of ictus does not increase the rate of death or disability at 6 months and might provide small but clinically relevant survival advantage in patients with spontaneous supratentorial ICH, 10 to 100 milliliter in volume, without interventricular hemorrhage. Japanese guideline for the management of stroke derived from such randomized control study clarify the surgical benefit under specific conditions, such as terminal hemorrhage of 31 milliliter in volume and severe brain compression. Several meta-analyses and other randomized control study revealed that age, no additional intraventricular hemorrhage, time from event to treatment, hematoma volume, and initial Glasgow scale correlate with outcome. Additionally, several reports indicate the correlation between a poor prognosis and the injury of the posterior rim of the internal capsule, focusing on horizontal progression of the hematoma. But we sometimes experience the cases with a poor prognosis who do not have the injury of the internal capsule, but present with the injury in the long insular artery region. So, we hypothesize a patient with terminal hemorrhage without injury to both the posterior rim of the internal capsule and the long insular artery region are likely to have the good clinical course. The purpose of this study was to confirm the relationship between damage to long insular artery region and prognosis in patients with terminal hemorrhage. Long insular artery is one of the medullary arteries, which rises from the insular segment of the middle cerebral artery and is anatomically intermediate between the lenticular striated arteries and the white matter medullary arteries. Stroke associated with sacrifice insular perforators extends from the top of the insular cortex to the periventricular coronal radiator, the radiologic battle line, AI line. So, we define initial long insular artery damage as hematoma reaching the highest level of the temporal ventricle, as observed on preoperative axial or coronal CT slice. The final long insular artery damage was defined as the presence of the white matter infarction adjacent to the highest level of temporal ventricle on coronal or axial CT or MR images on day 7 after surgery. The Ethics Committee of Nakamura Memorial Hospital approved this protocol. We retrospectively collected the data of 287 cases of terminal hemorrhage between January 2004 and March 2022. The patients who met the following criteria were excluded among them. 1. Initial injury to the posterior rim of the internal capsule. 2. Concurrence of aneurysm and moya-moya disease. 3. Complication of rebleeding. 4. Those who underwent surgical treatment over 48 hours after symptom onset. 5. Death. And 6. Detail unknown. Based on the CT or MRI images obtained 7 days after surgical treatment, we divided the patient into 2 groups. The patient who didn't have injury in the long insular artery at 7 days post-operatively were categorized Group A, while those with damage to the long insular artery region at 7 days post-operatively were categorized Group B. The primary outcomes was set the possibility rate of manual muscle testing, MMT scores over 3 at discharge day. And we also check retrospectively the initial pattern of hematoma distribution, volume of hematomas, symptom onset to treatment time, and surgical treatment performed. A total of 287 cases had terminal hemorrhage during our study period. Among them, 63 patients met our study inclusion criteria. Of them, 16 of the remaining 63 patients didn't have the long insular artery damage on the 7 days after surgical procedure. Table 1 shows the baseline characteristics of the study groups. Age, sex, and baseline clinical risk factors did not differ between the 2 groups. There were 11 cases in Group A and 9 cases in Group B that were positive for MMT scores over 3. Thus, Group A had a significantly higher rate of MMT score over 3 than Group B, as assessed using chi-square test. And Group A has significantly lower rate of initial damage to the lung insular artery region. Table 2 shows other measurement data of the study groups. Group A had longer time from onset to operation time and less initial hematoma volume than Group B, as assessed using Fisher exact test or Ampere t-test as appropriate. Seeing the variance inflation factor exceeded 10 when the initial lung insular artery damage and lung insular artery damage on 7 days after surgical treatment were included in the multivariate analysis. Only lung insular artery damage on 7 days after surgical treatment was employed. According to the multivariate analysis, the damage of the lung insular artery region on 7 days after surgical treatment was found to be the sole predictive factor for MMT over 3 at discharge day. In the absence of the initial damage to the posterior rim of the internal capsule, the final lung insular artery damage correlates with functional prognosis in patients with terminal hemorrhage in this study. The result of this study also reveals that the lung insular artery damage was significantly more common in patients with the initial hematoma expanding into the lung insular artery region. There are some possibilities in this reason. First is primary injury due to the destruction of the brain cells, mass effect by the hematoma, mechanical injury by the surgery, and also secondary injury such as inflammation or ferrotosis are considered. We believe it is useful to identify the origin of the long insular artery by using distal transsylvian approach. It is very important to detach the middle cerebral artery and the long insular artery to minimize traction-related damage to the vessels. In the shining green is also useful to identify and preserve the perforating branches of middle cerebral arteries. In conclusion, in patients without initial damage to the internal capsule, long insular artery damage might be a key predictor of functional prognosis following terminal hemorrhage. Further accumulation of cases are needed to discuss the approach and treatment options, especially endoscopic treatment or aspiration. Basic research to investigate the solution of the cause of primary and secondary injuries for terminal hemorrhage are also important. Thank you for listening.